Welcome to this lecture on equine dental radiography. My name is Molly Rice, and I am a veterinarian and a diplomat of the American Veterinary Dental College. I work for Midwest Veterinary Dental Services, which is a dentistry-based practice in Wisconsin. And this lecture has been a collaborative effort between Jessica Hunt, who's our dental resident, and then Travis Henry and myself. Before we get started, I really want to thank Universal Imaging for sponsoring this lecture. Our practice has used their Stalo DR systems for probably the last 4 or 5 years. We currently have 3 of their systems that we use in our dental practice. And we have been, one, thrilled with the quality of images, as you'll see through the course of this presentation. All of the images obtained in this lecture were from the Stalo DR system. And also their customer support is amazing. Not that we need it very often, because we have really no connectivity problems between the plate and the computer system, which is an issue that I have noticed in some of the other DR systems on the market just from use in various wet labs. We don't seem to have any of those issues with this system. So if you're interested in more information, you can see their website here or their sales email. I really encourage you to give them a call and find out more information about trying out one of these systems. So without any further ado, we'll get right into our lecture. So we're going to talk about obtaining sort of the common radiographic views of equine teeth. So that includes cheek teeth, incisors, canines, sinus, temporomandibular joints, and then at the end we'll go through a variety of sort of odd views that may not be as commonly known, but you may find extremely helpful depending on what you're looking for. Before I get started, I just want to make a quick note on orientation. So as dentists, we don't really follow what the radiologists always tell us. So if you're a radiologist, plug your ears. So when in vet school, the radiologist always said, point the horse's nose to the left. But if you're looking at teeth, so both in human dentistry and small animal dentistry, they have different varieties of how they orient these teeth. So basically, the maxillary incisors are going to be facing with the occlusal surface down or ventrally. The mandibular incisors are going to be facing with the occlusal surface dorsally. So it's as if you're looking at the horse. And if I have a skull here, I'll just show you. So your maxillary incisors will look like this, and your mandibular incisors look like that. Similarly, the left side of the horse will be faced so that the left side of the horse is pointing to the left, and then the right side of the horse's face will be pointing to the right. So by orienting your films this way, you immediately know which quadrant of tooth that you're looking at. In addition to this, whenever you're reading radiographs, and this lecture isn't going to delve into the interpretation that much, though I will make some points as we go along with various radiographs. But when you're interpreting your radiographs, you really need to have a full exam finding. So you need to have your full oral examination findings present so that you can correlate what you're finding on your oral exam with your radiographs. And this is sort of a pet peeve of ours because we get sent a lot of radiographs to read. And a lot of times we get sent radiographs out of nowhere with no accompanying history or oral exam findings. So it's really important to correlate your oral exam with your radiographs. So we'll start with the cheek teeth, and we're going to start with some extraoral views that you might obtain. So there's basically 2 views for the maxillary cheek teeth and 2 views for the mandibular cheek teeth. Now this is an interesting radiograph here. This was a young horse that had been imported from Europe, and prior to him being imported, he had had a 207 that had some non-vital tooth exposure, or pulp exposure, sorry. And this tooth had actually been extracted. It had an apicoectomy, so it had the tooth roots cut off. It then had endodontic procedures performed, and then the tooth was reimplanted into the socket. Now, this is a somewhat experimental procedure with various results. I would say the jury is still out as to whether this is a viable procedure in horses. I have to say I've never personally done this procedure in practice. I've seen various cases that have been performed like this, and I have to say my experience has not been good with the outcome, but I know that some people do this with some degree of success. So But as you'll see in this horse, there was quite a large cystic structure sort of surrounding this tooth. And interestingly, when this horse was first imported from Europe, it had had radiographs obtained. They were sent to us to review, and we had recommended extraction of the tooth at that time. Well, the owner decided not to listen to what we had recommended, and they just kept going with the horse. Well, then fast forward 2 or 3 years, all of a sudden the horse had this swelling on its face. And at this point, there was really no choice but to extract that. And once we extracted that tooth, that whole cystic structure was filled with inspissated purulent material, and the horse had an oronasal fistula at this point as well. So you can see where that apicoectomy had been performed. So when we image the cheek teeth, you have to keep a couple anatomical features in mind. First off, the cheek teeth quadrants are not sort of parallel to the midline of the horse's face. The horse's face is actually somewhat triangular shaped, which puts those interproximal surfaces, again, not perpendicular to the midline of the horse. It puts them at a little bit of an angle. And so when you're imaging the dental quadrants, you need to make sure that you're directing your primary beam through that interproximal space in order to set each of those teeth off as an individual entity. And we'll talk about that a little bit more when we show this in some videos. But there's 2 ways to think of this. One, if you put the plate alongside the horse's face, you'll see that's indicated by the black line on the image. That basically is parallel with the tooth quadrant, right? And so then that puts you, if you shoot your primary beam perpendicular to your plate, then you should be approximating those interproximal spaces pretty appropriately that way. The other way to think of it is to angle the tail of your generator about 10 to 15 degrees towards the tail of the horse, and then get your downward angle. And that'll put you about in that same estimation as well. The other tip for getting good cheek teeth radiographs is to open the mouth. And I cannot emphasize this anymore. When I went through vet school, everything we took were closed mouth obliques, and we could never really get good separation of the teeth. If you want to separate the right from the left, you have to open the mouth in order to give yourself space to do so. So we'll start with the cheek tooth maxillary dorsoventral oblique. You're going to center your beam at the rostral border of the facial crest. And if we look at that on the skull here, you'll see where that rostral border of the facial crest is basically in the middle of the dental quadrant, right? So we've got the 11, the 10, the 9, the 8 is missing on this horse, and then we've got the 7 and the 6. And I would say, you know, if you're constantly either cutting off the 11 or cutting off the 6, you're not centering your beam properly. Because even with an 8x10 plate, you should be able to, unless you have a really large draft horse, get all 6 cheek teeth on your x-ray plate. So then you're going to want to angle down 30 to 50 degrees. And your angle is going to change depending on the age of your horse, right? So if you have a younger horse, their teeth are longer. So you're going to need a steeper angle in order to separate right from left. With the older horses, when their teeth get a little bit shorter, you can probably decrease that angle so that you are distorting those teeth a little bit less. The only thing I will say with the older horses is that sometimes if you shoot too shallow, you might get separation from right from left. But the other thing that you have in these older horses is that the hard palate will then start to obscure the furcation or the apical region of these teeth. And I'll show you that on this next film here. So if you look on the picture on the left, you'll see that yellow arrow is pointing out sort of that hard palate, which is this bright white line that runs right through the kind of the apex and the furcation of those teeth. And you can see where it sort of obscures the apical view of those teeth. Everything looks just a little bit fuzzy. If we look on the picture on the right, you can see here where we shot just a slightly steeper angle, where we can see that root furcation a little bit more clearly, and we can see the tooth roots, particularly of that 209, highlighted a little bit more clearly as well. And on this view, it's very apparent that that bone has receded up to the level of that mesial buccal root on the 209. So, and I will say on these older horses in particular, sometimes you've got to take a couple views. You know, it may take you 2 or 3 dorsal ventral obliques and putting information together from all of those different views to get your diagnostic picture. So this is how we shoot the maxillary dorsoventral oblique. Again, we're centering the primary beam on the rostral portion of the facial crest. We're shooting perpendicular to the plate, and then you're getting your downward angle at that 30 to 50 degrees. And this is the type of image that you want to obtain. So the second view that we look at to evaluate the maxillary cheek teeth is the maxillary ventrodorsal oblique. And this is also known as the palatal root view. And if we just look at a cheek tooth here, so this is a tooth from an older horse, and you'll see that the maxillary cheek teeth have 3 roots. So there's these 2 buccal roots, and then we have the single palatal root here. When you're shooting the dorsoventral oblique, you're really highlighting these 2 buccal roots, so the mesial and the distal buccal root. When you're shooting this maxillary ventrodorsal oblique, you are then highlighting the palatal root here. And I will say this is probably most important in our older patients, because a lot of these horses with periodontal disease or just some, advanced attrition will start to have changes along that palatal root that might not necessarily be evident on that typical dorsoventral maxillary oblique. So this projection is positioned very similar to the mandibular ventrodorsal oblique, but instead of centering the beam along the ventral mandible, you're going to be centering the beam higher over the maxillary cheek teeth. You're going to angle upward at 45 to 80 degrees, again, depending on the age of the horse. You're going to have a steeper angle again for those younger horses so that you're separating those teeth properly. And you'll have a slightly less or a decreased angle for your older patients. And for some of these, you may need 2 radiographs, right? So depending on the length of tooth, kind of the prime age for these is, I would say 18 to 20, you can usually get all of the teeth in one view. But if they're much younger than 15, then you're probably going to need 2, one to look at the premolars and one to look at the molars. And that's, again, just because the teeth are that much longer. And we'll show that in a slide or 2. These may not be able to be obtained on really young horses, right? So if you've got those 5 to 8-year-olds, again, the teeth are quite long and you just really physically can't get the mouth open enough to create separation. And these are also difficult on miniatures, again, because of the length of tooth and the ability to open the mouth wide enough. So if you look at the video here, you can see where, this is very similar to how we're shooting the mandibular obliques, except instead of centering down here, we're going to be centering up towards the facial crest. And again, you're placing the cassette on the side of the face that you are imaging. So in this case, we are imaging a left maxillary quadrant. Now, the images on the left there are cropped down, right? So there's going to be a whole lot of information on the outside of that film that you're just not even going to look at. So all we're looking at is that palatal root view of those maxillary cheek teeth. And you'll see on the top that we're sort of highlighting the molars, whereas on that bottom image, you can see the palatal view of the premolars a little bit, whereas the molars are sort of getting superimposed with the mandibular teeth. So if we move on to the mandibular teeth, for the mandibular ventrodorsal oblique, again, this is similar to that ventrodorsal oblique that we just took of the maxillary cheek teeth, except now we're going to center along the ventral border of the mandible closest to you at the rostral border of that masseter, kind of where that masseter curves into the bottom of the mandible. You're going to angle up 45 to 60 degrees. Again, you're going to increase your angle for younger horses and decrease for the older horses. So this is basically what this looks like. And again, we're centering at that right where that masseter kind of rolls into the bottom of the mandible, and you're shooting up in that 45 to 60 degree range. And this is the type of image you would expect to see. So again, we have nice separation of from our right to our left, and this is showing a left mandibular oblique on this pony. So here's just a sort of a clinical case. Again, this isn't a lecture on interpretation, but I just thought I would put a couple of interesting radiographs in here. So this horse had non-vital pulp exposure of the 409. You can see that on the picture there on the left. And you'll see that this tooth has some changes associated with that non-vital pulp exposure. So we have some increased lucency in the apex of that tooth. And we have some apical blunting as well, and some widening of the periodontal ligament, kind of right where that red arrow is pointing along that distal margin of that tooth. So this is not going to necessarily be an easy extraction because that tooth lacks some structural integrity. But then if you look at the periodontal ligament space sort of surrounding those roots, it doesn't look widened or that loosened, right? So there's still pretty good attachment to that tooth. So the other cheek tooth view that we use for the mandible is this DV oblique. So this dorsoventral oblique kind of gives you a view of the occlusal surface and that interproximal bone. So this is really what you would want if you were trying to evaluate for periodontal disease, so for attachment loss of these mandibular teeth. Because if I go back, you'll see on this the ventrodorsal oblique, you've got a really nice clear view of the root apices, but the bone in between those teeth is somewhat obscured. Whereas if we go forward here, you'll see on the top here, this is an intraoral view. This was shot with a Metron Scanex system. So they're little flexible plates that you put in and you shoot kind of a near parallel technique. But that same horse, with an extraoral view, you can see you can get that same information with your DR plate. And this bottom image was actually taken also with the Metron Scanex system. So this was not the universal DR. But you can see where that really allows you to evaluate the crestal bone in between those teeth. And you can see that this was an older patient that had some blunting of that crestal bone between the 8-9, 9-10, and 10-11. So for this, again, you're going to place the cassette on the side of the image or side of the face that you're imaging, and you're going to shoot down at a 15 to 30 degrees. And this I would say is the view that takes probably the most fiddling to get right, even for myself that takes these, fairly frequently. I usually end up having to shoot a little bit steeper than you think you should. So here's Dr. Hunt just demonstrating how we obtain this view. So you can see that she's shooting the right mandible, and again, the part of the image that we're looking at with this is circled in red. So we're just looking at that occlusal surface and that interproximal space on that right mandible. So if we move on to the incisors and canines, these are best imaged with an intraoral placement of your cassette. Now, some people have trouble putting their very expensive DR plate in the mouth, and I totally agree with you. So I won't say that we never do it. We do buy some plastic bags that we put to protect the cassette from moisture from the mouth. And I will say that I only will put it on horses that are well sedated that won't be chewing on the plate. The other option is a variety of speculums. So you can certainly place the IllumiSpec. If you put their incisors back on the bite plate, then the screws on the bite plate won't show up or won't superimpose with important parts of the teeth. So you can use an IllumiSpec. Potoblock actually makes a very nice radiolucent bite plates for a McPherson type speculum. So there's a variety of things. Some people build tunnels for their DR plates, but really you need to get an intraoral view to get these images without superimposition of the maxillary or the mandibular teeth. So when you're placing these, so the upper right image is the maxillary cheek teeth, right? So we've got the cassette in the mouth. Let me see if I can bring my skull up here. So we've got our cassette in the mouth, and one plane is the X-ray plate here. The other plane is approximating the tooth angle, and then halfway between that angle and your plate is your bisecting angle, and that's the dotted line on the diagram. And basically you're shooting your primary beam perpendicular to that bisecting angle in order to get an appropriate view. And that, if you're doing your bisecting angle technique correct, you should get an actual length of the tooth, so you're not forelengthening or you're not foreshortening. So in most horses with the maxillary cheek teeth, if you think about how the nose sort of falls on the front of the face, you're shooting perpendicular to how their nose falls on their maxillary, across their maxillary incisors. The mandible is a little bit trickier for some people. And some people will do it with the horse's head down where they're standing kind of next to the horse's legs. I prefer to have them elevated on a headstand. And if you can elevate them such that the bars of their mandible are basically parallel with the ground, then you basically are shooting straight up at the ceiling. And you can see that on this image down below. So we've got our X-ray cassette, we've got our teeth, our bisecting angle is halfway in between, and then we're shooting perpendicular to that bisecting angle. So these are the types of images that you're going to get. And actually I should go back there. So this horse obviously has EOTRH, or equine odontoclastic tooth resorption and hypercementosis, but in addition to that, he had a very large cystic structure associated with that. Now this neoplasia would also be on your differential list with this. But in this horse's case, when we extracted those teeth, he had just a very large cystic structure that was filled with inspissated material. So the incisors and canines, orientation of films, again, if we kind of go back to the beginning, your maxillary incisors point with the occlusal surface ventrally, your mandibular incisors point with the occlusal surface dorsally, kind of as if you were looking at the horse. And then the right, again, faces with the horse's nose to the right, and the left faces with the horse's nose to the left. So for the maxillary incisors, again, we're shooting basically perpendicular to the way that that nose falls to get your proper bisecting angle technique. This one is pretty straightforward and pretty easy. To get the oblique views, you're going to, take that same angle, but then come around 45 degrees to the side and then 45 degrees to the side. For the mandibular incisors, again, if you elevate the horse's head so that their bars are roughly parallel with the ground, you can see where you end up shooting basically up straight to the ceiling to get this view. And then with the mandibular canines, again, you're coming from a more lateral position and shooting up at an angle towards the mandibular canine and the third incisor. So we'll move on to the sinuses. And there are a variety of projections used to evaluate the sinuses. So we have a lateral-lateral, as we've shown here on the right, and a dorsoventral, as Dr. Hunt is showing you in the video. Now, when you're looking for a fluid line in the sinus, it's often helpful to orient your film in this downward position, because then you can kind of look for that fluid line. And again, the horse's nose needs to be positioned sort of in that downward angle as well, so that you're not putting your fluid line in the plane of the infraorbital canal. So for the sinus lateral view, we remove the speculum for this. And again, we position the head with the nose down to accentuate a fluid line if present. Again, if the horse's head is level, that fluid line might get obscured by the infraorbital canals. The cassette is placed on the side of the face that you're imaging, and the beam is centered at the rostral border of the facial crest. So you're going to get an image similar to this. And depending on the size of your horse, this was a pony, so we were able to get basically the entire face or the entire head on the film. In a larger horse, you may not get as far out to the sixes there, but you want to make sure that you get the entire frontal sinus, which is above the ethmoids here, kind of on the rostral border of that cranium, so that you can get the entire sinuses in your view. Here's a lateral projection on more of a horse-sized horse. Again, you can see we did get all 6 cheek teeth in there, and we have the entire frontal sinus in. This horse showed the maxillary septal bulla very clearly. I would say that's not a common finding, but I just thought I would point that out, where you can see kind of the double-layered maxillary septal bulla that separates the rostral maxillary sinuses from the caudal system, which is the conchofrontal and the caudal maxillary sinuses. So for the dorsoventral sinus, you're going to place the cassette under the head and center the beam on the midline, level with the rostral edge of the facial crest, as you'll see here. And it's really important on these dorsoventrals to try to get that septum sort of lined up, as you'll see in the central film here. If you get obliqued a little bit off either which way, you can really obscure some of these anatomical landmarks. So try to get that septum lined up as straight as you can. The offset views can be helpful if the horse has a sinus infection. The offset views really give you a better look at the ventral conchal sinus, which is sort of located, pardon me, along midline. So you'll see here, and in our practice, we use a Gunther speculum to offset these, but you can easily use some rope or twine to have, you know, somebody pull the mandible to one side or the other. So this was a horse that came in for evaluation of a facial swelling. So he had had some teeth extracted several years prior somewhere else. And he had had a sinus infection at that time that had resolved partially, but he kind of went on and off with nasal discharge over the courses of the years. And the owners really didn't follow up with anybody very much with that. So when he presented to us, he had this sort of bulge along his right frontal sinus, and when we took radiographs, you can see where he has some thinning of the cortex of that bone indicated by those red arrows, as well as deviation of his septum indicated by the blue arrows. So this horse ended up, when we opened up his sinus, he had inspissated purulent material that had just been building up over time and had created enough pressure to start distending and thinning the bone. We thought initially that, you know, neoplasia might also be on the list, but in his case, it was just a very chronic, untreated sinus infection. So to kind of wrap up here, we're going to go into some of the sort of ancillary different views, one of which is the temporomandibular joint. And there are several ways of imaging this. There's a dorsal to lateral, ventrolateral oblique, as well as a rostral sort of skyline view, and we'll go through both of those. But just giving you some anatomical landmarks for these images, you'll see the temporal bone is indicated by the blue. The TMJ space is that space indicated by the red, and then you have your mandibular condyle indicated by the green arrow there. And I don't know if I can show you the skull here, but basically you're looking at the joint kind of in that framework there. So you've got your mandibular condyle here and your temporal bone here, and then the joint space there. Sorry, it's a little hard to have the skull on my shoulder, but and then you've got your parietal bone in purple there. So there are a couple good references on obtaining these films. They're a little bit tricky when you're first learning them, but once you've got them under your belt, they're actually not that difficult. The hardest part with this one for me is that I often end up having to be up on a step stool or have the horse sedated so that it's holding its head quite low to the ground because I'm short. But basically, you end up standing over the top of the horse's head, and you're shooting kind of right down towards the ipsilateral ear, down at a 70-degree angle with a slight caudal tilt of 15 degrees. And the bottom picture really shows kind of the angle of that X-ray beam towards the base of the ear. It's usually helpful to have somebody hold the ear back because otherwise the ear will superimpose over your temporomandibular joint. So here's Dr. Hunt sort of demonstrating this, and again you can see she's up on a step stool, and this is a fairly short pony, but again the cassette is placed on the side of the horse's head, and then you're shooting sort of down from caudal to rostral, and then across based at the base of the ear. The other radiographic projection is described in this paper. And again, this is a little bit more of a sort of a skyline view of the temporomandibular joint. Some horses, if they won't tolerate you, oops, let me go back here. If they won't tolerate you standing over them, which is the case with some horses, this view is usually a little bit better tolerated. So again, the plate is on top of the horse's head like a hat, and you're shooting kind of a skyline up. And the important thing of this view is to get you're angling up at 45 degrees, but also lateral from about 30 degrees. And that lateral bend is very important for sort of highlighting this temporomandibular joint. And again, you can see the ear on this film. Another sort of odd view, or another couple odd views, are the Wiener Schuler, which is a view that images the maxillary sinus, the temporohyoid, and then we'll just talk about blind wolf tooth view at the end. So this Wiener Schuler view is not a very well-known view. This was a view that was put out by Hubert Simhofer and his colleagues out of Vienna. And if any of you are German speakers, that's what Wiener Schuler is actually German for School of Vienna, right? So he was at the University of Vienna when this paper came out. So that's, I believe, where the name came from. But the cassette is basically placed on the bridge of the nose, and then you rotate the head 20 degrees towards the affected side, and then you're shooting at about a 30-degree angle from the sagittal plane. And this diagram actually illustrates that quite nicely. And this view is really useful for evaluating the orbit, the zygomatic bone, the maxillary sinus, the ventral conchal sinus, conchofrontal sinus, and the infraorbital canal. And it can be a useful auxiliary view in addition to your normal sinus lateral and sinus oblique views, particularly if you have areas sort of in the frontal sinus or around the orbit. I have also used this in cases where you have sort of fractures in that orbital or periorbital area that just aren't being well defined with the more traditional radiographic projections. So I encourage you to look up this paper. There's quite a few diagrams sort of indicating the anatomical features that you'll see on these radiographs, because they're not typical. You know, the anatomy looks a little bit different on these views than it is for the views that you're used to seeing. So here's a case in which this radiographic projection actually gave us useful information. So this was a 4-year-old that had a swelling on her right maxillary kind of facial crest area that had a draining tract. And on the left here is the skull, the dorsoventral skull projection. And on the right is the Wiener Schuler projection. And you can see on the Wiener Schuler that there's a very obvious bony sequestrum that's present that's not as readily apparent on the skull dorsoventral projection. And so here's her right maxillary dorsoventral view, and you can see that she obviously had some trauma to her sinus at some point. And again, the skull DV and then the Wiener Schuler projection showing that that sequestrum there. This is another example where the Wiener Schuler was helpful to us. This was a 3-year-old horse that presented with an expansive mass in his frontal sinus region. He had kind of a change of shape of his face. And when we radiographed him, we saw that there was an increased soft tissue opacity viewed in his frontal sinus. And you can see that even on the dorsoventral projection in that kind of caudal-maxillary frontal sinus region, there was an increased soft tissue opacity. And so these are the Wiener Schuler. I have them oriented the same way so that you can kind of compare left to right. And on this particular view, you can see the eye. That's the beauty of these digital radiography systems. The soft tissue that you can see on these is quite amazing. So, but you can see on the right side where the facial swelling was, where there's kind of this stippled soft tissue opacity, sort of just kind of surrounding that orbit in the frontal sinus. And this horse actually we ended up sending him in for a CT and exploring his sinus, and he had a mass that we removed. And when it was biopsied, it came back as a possible early fibrosarcoma, but it also had embedded aspergillus hyphae in it. And so we ended up treating him with miconazole in his sinus, and we did get it to clear up, and he's about 2 or 3 years out now without recurrence of that mass. So we think it was sort of a fungal infection that was just very unusual and again caused some expansion of his frontal sinus, but he's doing well post-surgery. So the last couple of views we'll talk about here are the temporohyoid. You can view this both with a lateral projection and a ventrodorsal or a dorsoventral. And as pictured here, we have a ventrodorsal where again, the cassette is positioned on top of the head. I will say when you're trying to image the temporohyoids, it's very important to get the head sort of stretched out. If their head is sort of ventroflexed, you're not going to get imaging of that area quite well. And you're basically centering your beam right between their ears in order to get this imaged properly. So, and then on the lateral, you're basically taking a lateral of the guttural pouch region. And this is, again, good for sort of imaging those guttural pouches. You can sort of see the stylohyoids. I would say the lateral view is not as useful for evaluating the temporohyoid joint just because there's so much superimposition. But you can determine which one is the larger structure, or the larger structure is closest to the generator because you have magnification. So the one closest to the plate would be the smaller. So here's an example of the ventrodorsal. So again, we've got the pony's head stretched out, we've got the plate along the forehead, and then we're shooting straight up at that temporohyoid region. So here's an example of a horse that developed facial nerve paralysis after dentistry. And you'll notice that that right temporohyoid joint has a little bit of a bulbous, sort of enlarged appearance. Now, radiography is not the most sensitive for diagnosing this, but in some cases like this, you might get lucky and get a kind of a definitive answer on your radiography. In a lot of cases, I think these can be diagnosed with guttural pouch endoscopy, as you'll see in this case, where there's an enlargement of that proximal stylohyoid. So the last view that we'll discuss are the blind wolf tooth views. So when you're doing your oral exam, it's very important to palpate those bars before you open the mouth with the speculum, because that's really the easiest time to feel if they have unerupted wolf teeth. And for this view, you're going to put the plate on the side of the image, or on the side of the face that you're imaging. And then you're going to center the beam just rostral to the facial crest, kind of over the second and third maxillary premolars. And you're going to angle up 10 to 15 degrees for the maxilla and down 10 to 15 degrees for a mandibular blind wolf tooth. And again, these have to have an open mouth in order to separate the quadrants. So here's an example of a blind upper left wolf tooth. And the reason why it's pretty important to radiograph these before you just dive into extracting them is these teeth can be oriented in very different positions. Usually they're blind or unerupted because they're not in a typical, sort of straight up and down orientation. They're usually tipped on their side one way or another. And in this case, on the image on the left, you can see that that has quite a long root, sort of extending back over the maxillary sixth tooth. So it's important in my mind to radiograph these so that you know kind of what you're getting into, because some of these are very easy. They're just small little teeth tipped on their side, whereas other ones like this is going to be a little bit more of a procedure in order to remove that tooth. So finally, let's go into some common mistakes. So one of the common mistakes that we see on films that get sent to us for review is non-diagnostic films. Now, hopefully, after hearing this presentation, you will be set up to take more diagnostic films if you've struggled with this. But there are some things that we can kind of tell you to look for on your films to kind of help you determine if they're diagnostic or not. Foreshortening and elongation of teeth, whether it's your intraoral incisor radiographs or even on your cheek teeth, that can really change your interpretation, and because it changes the anatomy and it changes how you view things. So that can sometimes cause some misdiagnosis if you don't get properly oriented films. Cone cutting and improper plate position can also sort of hamstring you when it comes to reading your films, and then motion artifacts can be problematic as well. So one of the things that can kind of help you determine if your film is diagnostic is, can you identify structures that you should be able to identify? So the interproximal bone, you should be able to see that nice little kind of V-shaped bone in between each tooth. Each tooth should look like its own individual structure. You shouldn't have sort of blurred borders in between those teeth. The infraorbital canals, as you see here, pointed out on the maxillary views. I just pointed that out. I should have pointed that out back in the sinus, but that's where you can sometimes think that you have a sinus fluid line, but you just have to know that those infraorbital canals are there. And then the periodontal ligament space is that kind of bright white line, and then the black sort of halo sort of surrounding those tooth roots. And that black halo is very important. And if you get widening of that periodontal ligament space, that can indicate a disease process. And then also, you know, in some cases you may get some ankylosis with age. So sometimes that periodontal ligament space starts to get obscured, and that can be useful information if you're planning on extracting a tooth, whether there's a defined periodontal ligament space or not. So here's an example of a non-diagnostic versus a diagnostic radiograph, right? So on the left-hand side, we've got our downward angle appropriate, you know, so we've got separation of the right from the left, but those teeth are not really defined as individual structures, right? Kind of the borders all sort of mesh together, whereas the film on the right, you can see that interproximal bone in between each of those teeth. Now, as you get towards the middle of the quadrant, the 8 and the 9 are usually fairly parallel to one another. So sometimes, like if we go back here, you can see the 8 and the 9, there's really not an identifiable interproximal bone space there, but you can see it in all of the other spaces. So you know that that's just related to that horse's anatomy or his age. So, and again, how are these radiographs obtained? How do you figure your way out of this problem? So on the left-hand side, on that non-diagnostic view, the primary beam was angled towards that black line. So you were basically perpendicular to the midline of the horse and not angling that tail to tail. So you're not angling through those interproximal spaces. You're sort of off kilter from those interproximal spaces. You can fix that by shooting perpendicular to your plate, which is the black line sort of along the side of the face. If you shoot perpendicular to your plate and then get your downward angle, then you'll be able to fix that problem. Foreshortening can also be problematic with incisors. So this horse had been referred to us for extraction of the 201 incisor. It had kind of some discoloration on the crown. And on the film that had been sent to us, it was kind of hard to tell. It kind of looked like there might be some root resorption. However, when we obtained a more appropriately positioned film, once the horse was in our clinic, we could see that there really was no great indication to extract that tooth. The tooth might be just slightly shorter than the 101, but it had a nice periodontal ligament, and there was no pulp exposure evident. So foreshortening on these incisors, you get that by shooting too steep. And if you think about it, if you look at that film on the left where you're really seeing those clinical crowns as you would if you were looking down at the tooth, that's from shooting too steep. So you have to lessen your angle in order to get a more appropriate length. If we go the other way, if you're elongating these, your angle is too shallow. And the other way that I like to tell people to think about this is if you think about the sun. Right, so if you're outside at noontime where the sun is very high in the sky, your shadow is going to be very short, right? Because that sun is at a very steep angle. Whereas in the evening, when you've got the sun very low on the horizon, your shadow is going to be quite long. So you're going to elongate things. So you have to, and if you do your bisecting angle technique appropriately, then you won't foreshorten or elongate the incisors. And so here Dr. Hunt is showing an example of what would cause elongation. Cone cutting is another problem, and this is basically, you're losing out on information of the surrounding structures. Most of these digital sensor plates are designed to be fully exposed, right? You're not collimating down to a very, small image, which, technically is probably not great from a radiography or, radiologic exposure standpoint, but for the most part, we want to illuminate or expose our entire sensor so that we get all of the information that we can. So you can see on the left where we've cone cut, so we're missing information on that sinus. We've got a decent view of the teeth, but we're missing quite a lot of information from the sinus. Another common mistake is plate positioning. So again, if you're commonly cutting off the 11 or if you're commonly cutting off the 6, you need to kind of remember your anatomical landmarks. So again, remember that the middle of the dental quadrant is the rostral border of that facial crest, or it's kind of where that masseter rolls into the bottom of the jaw here. And if you center your beam there, you'll get all 6 cheek teeth on there. If you're still having problems, you got to remember that that 11 basically sits below the orbit, just in front of the medial canthus there. And then it's pretty easy to palpate the 6, and you can even put a piece of tape there on the 6 and a piece of tape on where the 11 is, and then shoot in the middle, which will put you right at the rostral part of the facial crest. Motion is another common artifact, and I would say on these sinus laterals, it's probably very common because you don't want the horse's nose pointing down. So a lot of times I'll rest their nose on my stool, or a trash can lid, something to just kind of keep them from swaying just a little bit, because motion will definitely cause issues with interpretation of films. So here's another example of a motion artifact on the left, and you can see where the speculum was just a little bit blurry. Those teeth are a little bit blurry, whereas on the right, we've got a nice crisp film. And here's an example of using the Illumispec to take some incisor radiographs. You can make this even better, but like I said, by moving their teeth back on the bite plate, you can see we've got this horse where we would be if we were floating it because it's all the way up to the front. But if you move the crowns back to about where those screws are, then you'll have less superimposition with the aluminum bite plate and your teeth. So you'll have a little bit better view. So the biggest take-home message, again, open the mouth for your oblique views of your cheek teeth. This will allow you to get proper separation and view those dental quadrants more effectively. Also, image both sides of the horse whenever possible. Even if you're only charging for the side that you're viewing, use that patient as your normal, right? Horses' teeth change quite a lot with age. And even as a dental specialist, I do this often because, like I said, they change a lot with age. And sometimes, you may miss a subtle finding on a horse unless you're comparing it to that horse's opposite side. So, get in the habit of taking both sides when possible. And this radiograph here is a horse that we did a mandibulectomy on. He had a squamous cell carcinoma up by one of his incisors. So our solution to that was to do a mandibulectomy. So that's basically all. I hope you enjoyed this lecture. And I want to thank Universal Imaging again for sponsoring this lecture and sharing it with you. And I hope this helps. Thank you.